Hello, good afternoon, everyone. I would like to thank KAD for giving me this opportunity to make this presentation. I've got no conflict of interest. I am going to do a brief overview, and my topic is updated treatment guidelines for atopic dermatitis. I did a review of several guidelines, as you can see. Some of them are quite recent, and usually guidelines guidelines are made after a lot of review of multiple studies, and usually the studies are graded according to the quality. They could be grade 1, 2, and 3. And according to these studies, then clinical recommendations are made according to the highest quality studies. So I will go straight into it. The aim of atopic dermatitis treatment is usually to control inflammation, to prevent worsening, and to treat the complications. And usually the treatment starts with education of the parents or the patient. And this is normally followed by treatment of the disturbed skin barrier that is present in atopic dermatitis, and avoidance of relevant allergies or irritants, and finally the treatment of inflammation. This is a summary of treatment of atopic dermatitis. I will not dwell into details because most of us are dermatologists, but you can see that there's baseline therapy, there's therapy for mild, moderate, and persistent eczema. Usually the baseline therapy is, of course, the education, use of emollients, and avoidance of relevant allergens or irritants. And this is normally followed by the use of anti-inflammatory medications for mild eczema. And these are usually topical steroids and topical calcineurin inhibitors. And as the eczema becomes worse, according to the classification, then there's addition of phototherapy and also something called wet therapy, which I'll mention later. And finally, if the eczema is severe, then there may be hospitalization, and then there may be the use of systemic immunosuppressives, as well as light treatment. So I'll immediately delve in the topic of emollients, which Dr. Jenga has gone into the details. I'll just say something about them. And generally, there are two types of emollients. There are those that are very plain and lacking a lot of active ingredients. Then there are others that have extra ingredients, as Dr. Jenga alluded to. Particularly, she talked about oat extracts. She even mentioned bacterial lysates. Emollients. Okay, emollients are one of the basic mainstays of treatment for atopic dermatitis, but you should be aware that they can also be the problem that flares your dermatitis. And these two very important facts, they can cause irritation and contact allergy. And on the right side, I have just quickly outlined a few of the products that can cause irritation. To mention a few: urea, propylene glycol. Then there are those emollients with proteins that can cause sensitization and allergy. And then, of course, as has been mentioned before, there are others that actually can be allergenic, like lanolin. So emollients usually are not well tolerated when the skin is in acute flare. So one must first treat the acute flare with anti-inflammatory agents like topical steroids and topical calcineurin inhibitors. And then there is the issue of wet traps. Wet traps have been found to be very useful to reduce the flare of atopic dermatitis, so that thereafter you can be able to use emollients effectively. And the anti-inflammatory medication needs to be in sufficient strength, in sufficient dosage, and you need to have the correct application. Of course, this depends on the age and where the dermatitis is, etc. Some highlights about emollients. Recent studies have found that even if you use emollients during the first year of life judiciously, you will not be able to prevent the incidence of atopic dermatitis in predisposed babies in the first 3 years of life. And indeed, the judicious use of emollients seem to be associated with an increase in the incidence of skin infections. And the recommendation was that caregivers should pay particular attention to hygiene. Another study that was done recently, this involved also judicious use of emollients, as well as early complementary feeding. And again, there was no reduction in incidence of atopic dermatitis. So let's come now to the anti-inflammatory treatment of atopic dermatitis. Basically, you can divide it into two. There is reactive treatment, where you apply the anti-inflammatory on the lesional skin, and then after the inflammation has settled, you can stop, and then you can taper. This is normally used for, you could say, for atopic dermatitis that comes and goes, that is recurrent. But when it comes to atopic dermatitis that is very persistent, proactive treatment is what is recommended, where you treat with the anti-inflammatories until the inflammation has subsided. Then you continue to apply the anti-inflammatory to the affected areas at least 2 times a week. And of course, this is also accompanied by emollients. And it has been found that early aggressive proactive treatment has been found to decrease the later development of food allergies. Now, let's come to this very beautiful diagram. It's a little bit busy, but I think it will be important when discussing the new therapies in atopic dermatitis. As you can see, it all starts with the barrier dysfunction and the introduction of allergens, which are conveyed by the Langerhans cells to the dendritic cells, and this sets up a whole cascade where the dendritic cells direct the formation of type 2 lymphocytes, which also elaborates a lot of cytokines. You can see in particular IL-4, IL-13, you can see IL-31, and as well as that, you can see that as the eczema goes from acute to chronic, there are even more types of cells that come into play, including Th17, Th22, and even Th1 subsets. And all these cytokines have a role to play in the barrier dysfunction, as you can see at the top there, barrier disruption. And others have a role to play in causing the skin to lichenify, like Th22 causes lichenification. So you can see that in atopic dermatitis, there's change in the column cytokines as the atopic dermatitis progresses. I just want you to pay a particular attention to that. This other very busy slide is also very important because you can see that it is portraying different kinds of people, European, Asian, pediatric. And when you look at, that is the clinical phenotype. But when you look at what is going on immunologically, there also seems to be a difference in the subtypes of cytokines that are produced. So I also wanted you to note that. And then you can also see in terms of the epidermal barrier also, there are differences. The European American seems to have a lot of reduction in filaggrin, for example. Others don't show as much differences in filaggrin. So it means that, this shows that different kinds of populations will have different production of different cytokines, so to say. So this may play a role in the treatment of atopic dermatitis in the future. So immediately I will go forwards and discuss a few of the new treatments of atopic dermatitis. Of note is crisaborole cream. I think I mentioned this in a previous talk before. It is a topical phosphodiesterase inhibitor that seems to be useful in mild to moderate atopic dermatitis. It has a reasonable safety profile, but may also cause a little bit of burning sensation. Phosphodiesterase inhibitors, they work to reduce the production of cyclic AMP. Cyclic AMP is normally responsible for producing inflammation, as well as producing an IgE environment. Presently, there are ongoing studies to compare this with topical steroids and topical calcineurin inhibitors, so that we will be able to know where exactly will it fit in this treatment. This is a very busy slide. I will not say much about it, but the PDE4 inhibitors, they look like little stars. You can see them there. They are present in multiple areas of this very busy slide. So next, we shall come to one of the new treatments, and this is a biologic, and the one that is well known is dupilum. Dupilum. I'm having a problem with the pronunciation, but it is a human monoclonal antibody that tends to block the IL-4 and IL-3 receptors. It is the first biologic that has been approved for the treatment of moderate to severe atopic dermatitis, where you need systemic therapy. And as you can see, it has been approved even from up the age of 6 years. It is administered in the following way. I don't think I need to go into that, but it is a subcutaneous injection, and it works quite fast. In about 4 weeks, you should see some good clinical outcome, and it takes care of pruritus significantly only after 2 weeks after you initiate the treatment. And it can also be combined with daily emollients and may be combined with topical anti-inflammatory treatments if needed. It has a reasonably good safety profile, doesn't need routine lab monitoring. The main side effects are actually conjunctivitis and blepharitis, injection site reactions, and there's something called the red face reaction and arthralgia. As you can see, the results are reasonably satisfactory. I can't see the next slide. Okay. Sorry about that. So there are also other biologics apart from dupilumab, which are coming up, and you can see that there are several ongoing studies, phase 3, phase 2. And then we shall come to the latest kid on the block. And these are called the JAK kinase inhibitors. And I want you just to have a quick look at this diagram. The JAK inhibitors are derived from a family of tyrosinase. And what usually happens is that, as you can see, that there are some cytokines that have attached themselves to the cytokine receptor on this molecule, and this leads to the phosphorylation of the molecule called JAK, which is phosphorylated to become STAT. And then the STAT molecule is taken up and it induces gene expression, and this gene expression causes proliferation, and this causes production of pro-inflammatory cytokines. So have a look at this other slide as well. JAK inhibitors are actually basically 4. There's JAK1, JAK2, JAK3, and type 2. And from this diagram, you can see that there are multiple cytokines that can be affected by JAK inhibitors. And if you look on the left-hand side, you can see JAK1, 3, JAK1 and 2 are able to block IL-4 and IL-13. And these are the main inflammatory cytokines that are present in atopic dermatitis. But you can see that there are others on the right-hand side, including those for psoriasis, IL-23, etc. So in summary, you can see that JAK inhibitors have a very broad spectrum of action, and they block several cytokine pathways. So topical JAK inhibitors are also in the picture, and at this time I came across daigositinib, which is a topical JAK inhibitor, which is actually now being used in Japan. It has a decent side effect profile, and one of the main side effects, I think, is an acne form eruption, particularly if it is applied on the face. In terms of oral JAK inhibitors, baricitinib was the first JAK inhibitor to be allowed in the market, and you can see it was allowed in 2020 for the management of moderately severe atopic dermatitis. But it has been already in the market for the treatment of rheumatoid arthritis. So there has been a bit of experience with it. You can see that this JAK inhibitor is orally taken, and it has a very rapid onset of action. Within a week, it has improved the symptoms of atopic dermatitis. And the most frequent side effects as per this time is upper respiratory tract infection, headaches, and increase in blood creatinine kinase levels. What are the favorable aspects of baricitinib, which is a type 1 JAK inhibitor? It is an oral formulation, it has a lower cost, and it can be modulated. That means you can modulate it according to the activity of your eczema, for example. Upcoming JAK inhibitors, which have already passed through phase 3 studies. One is upadacitinib, which is a JAK1 inhibitor again, and there's abrocitinib. Upadacitinib also has been in the picture for the management of rheumatoid arthritis. And a recent study called the Heads Up study has actually shown that upadacitinib has a superior outcome compared to dupilumab. So that's an important point. And again, its main side effect, I think, is an acne form rash. that comes on the face. So this is a summary of a clinical approach to the patient with refractory atopic dermatitis. And I think most of this we have already actually talked about. You confirm the diagnosis, you exclude differentials, you ensure that the patient is well educated on barrier function and removal of trigger factors. And then you do proactive treatments that I talked about. And finally, in very severe cases, you need to go to phototherapy, systemic immunotherapy, and of course, the new kids on the block. Biologics have been in the picture of atopic dermatitis, I think, since 2017. And now, more recently, the JAK inhibitors have come into play, I think, in 2020. This is a comparison between the two latest kids on the block. I assume it's going low. Need to charge it. Sorry about that. You can see the differences between dupilumab and JAK inhibitors. Dupilumab is usually given as a subcutaneous injection, whereas JAK inhibitors are oral. With dupilumab, you do not need any lab follow-up. With JAK inhibitors, you do need some lab follow-up, and we still don't know much about the side effects. Dupilumab is slower acting than JAK inhibitors, and the cost of dupilumab is much higher compared to the cost of JAK inhibitors. And what is of note also is that, okay, dupilumab has a limited spectrum, but JAK inhibitors have a very broad spectrum, as I showed you previously. So it means that JAK inhibitors can be used in somebody with multiple comorbidities. Maybe they have rheumatoid arthritis and they have eczema, or they have rheumatoid arthritis and maybe alopecia areata, or something like that. So finally, I just want to give a few highlights. The take-home messages is that atopic dermatitis is really a very heterogeneous disease, and it has multiple pathways, as I've shown you. Also, the phenotypes also can be quite variable. You can have people with classical atopic dermatitis. You can have atypical patterns. You can have those who are more prone to infections. You can have those who develop asthma and so forth. And so of note is that the genetic mutations in atopic dermatitis, they relate to the barrier dysfunction, but they also relate to the immune dysfunction. And as I have showed you, immune pathways for acute dermatitis differ from those of chronic atopic dermatitis, and also depending on the different populations, they also seem to have variable kinds of signaling pathways. So I foresee a future whereby the identification of specific phenotypes and endotypes may be necessary in order to give targeted therapy. And I think that personally, I think the future is really bright. But as you can see, what our problem is. I hope that I hope that this can be taken care of in the future. And I thank you very much for listening to me. I had a few hiccups, but I'm glad that I have been able to do this presentation. Thank you very much.